Hello, my name is Jessica Wisdom. I'm going to be doing a 5-minute lecture on Hashimoto's thyroiditis. I absolutely love endocrinology, and it's hard for me to condense all of that endocrinology love into 5 minutes, but I'm going to do my very best. What is Hashimoto's thyroiditis? It's an autoimmune disorder involving chronic inflammation of the thyroid. It is an autoimmune mediated destruction of the thyroid gland involving apoptosis of thyroid epithelial cells with diffuse lymphocytic infiltration of the thyroid. What does all of that mean? It means that this is a gradual thyroid failure that leads in a decline in thyroid hormone response, leading to thyroid underactivity over time. It is also called acute lymphocytic thyroiditis, which is related to that diffuse lymphocytic infiltration of the thyroid. It's the most common cause of hypothyroidism in the United States. In other countries, you may see that it's more likely to be food related. In the United States, we don't have a lot of food scarcity, so that's not what you're going to see. For you as the provider, it's important to understand the difference in Hashimoto's versus hypothyroidism. Hashimoto's is an autoimmune problem. Hypothyroidism is a gland problem. Hashimoto's may lead to hypothyroidism, and in most cases it does, but not all hypothyroidism is Hashimoto's. Things that make you more at risk for Hashimoto's thyroiditis are first, sex. Females are more likely to be affected. In fact, the sex ratio is 7-1. Age, people who are of middle age are more likely to be diagnosed with Hashimoto's thyroiditis, but it can also be diagnosed in children and in adolescents. There's a strong hereditary link. Also, having other autoimmune diseases puts you at a greater risk. People with type 1 diabetes or rheumatoid arthritis, for example, are at a greater risk. And people who have had radiation exposure in the thyroid area, like people who have had a lot of dental work done, may be more at risk. Your physical exam and your review of systems are very important to the diagnosis of Hashimoto's thyroiditis, so it's hard to really narrow it down to 3 key things that you need to know. But for your physical assessment, you're looking for those hypothyroidism signs. So everything has slowed down. Their skin is generally cool, pale, and dry. This is going to be related to a decrease in blood flow resulting in hyperkeratosis that results in roughness of their skin. They're going to have a lot of that periorbital edema around their eyes. It's kind of similar to that exophthalmos that you're going to see in Graves' disease. And finally, a goiter. Maybe. Not everyone with Hashimoto's has a goiter. However, you need to be palpating their thyroid every time to assess for that and assess for changes in the size, in the shape, and any irregularities. For the subjective data, you're going to want to ask them if anyone in their family has any thyroid issues of any kind, whether it's Graves' disease or hypothyroidism or Hashimoto's. You want to know about any kind of thyroid issues that they may have in their family. Next, have they had any recent illness or stress? That's important because those things can initiate the response of Hashimoto's thyroiditis. And have you recently had a pregnancy? Postpartum Hashimoto's thyroiditis does happen. Most of the time, those things does resolve, but it does increase their risk of thyroid failure in the future. And I just put this little bonus down here. Extreme fatigue and constipation are things that their patients are going to complain of. They're going to complain of weight loss, and basically everything is slowed down because of the hypothyroidism response. Lab testing, you're going to draw a TSH and a T4 like you would for any hypothyroidism. The only change here is you see that they have hypothyroidism and you draw a thyroid paradoxase. If it's high, that's very indicative of Hashimoto's. If it's normal, that doesn't necessarily mean that they do not have Hashimoto's, but if it is high, it is very indicative. The most common treatments, if you have a patient who comes in and this patient is just very proactive about their health maintenance and they know they have a strong family history, then observation may be all that's necessary if they have no thyroid involvement and all their labs look great. They just may want to follow it for now. But most of your patients are going to come in with a complaint. And if they've got a complaint, they probably have thyroid involvement. So draw those labs. And when they come back, they're probably going to need synthetic hormone replacement. Synthroid or levothyroxine really dominates the market in that area. Some providers are very particular about whether or not they allow their patients to take Synthroid versus levothyroxine. So as a nurse practitioner or a PA, you may want to talk to your collaborating physician and see where they stand on that. After 6 to 8 weeks of treatment, you're going to bring them back and have their labs repeated because you want to make sure they are within normal limits. Seeing an improvement is not enough for this lab because you want them to fall within those normal limits. And if they come back and their TSH is still high and their T4 is still low, make a medication change and bring them back again and repeat that until you can get them within normal limits. Once you do, you can bring them back yearly. Your priority teaching points for your patient are make sure they understand that they have a dependence on synthetic thyroid hormone medication and that is going to be lifelong. Over time, they're going to need more hormone replacement because just as the nature of Hashimoto's is, they're going to have a gradual failure. So they're going to need more hormone medication. Next, do not stop taking your medication suddenly. You came in for a complaint, it was weight gain or of tiredness or whatever you had. If you stop taking your medication, those symptoms are going to come back. And not only that, you're increasing your risk of thyroid cancer and myxedema coma. So it's definitely not a good idea to stop the medication suddenly. And finally, you want to make sure that you are coming to those appointments because adequate monitoring of serum thyroid levels is imperative to adequate care, as we discussed on the previous slide. These last two I threw in because these are important for you as the provider to understand. Manual palpation of the thyroid gland is so important because you need to be assessing and documenting what you feel in that patient's thyroid every time, because nodules and changes in the size and any changes in the texture of the thyroid are important to document because those changes can indicate cancer, and it's important to get your patient a thyroid ultrasound if it's necessary. And then finally, if you're uncomfortable treating this patient, refer them to endocrinology. They're the experts and they're there for a reason. All right. That's all I've got for you. I know that was quick, fast, and in a hurry. Thank you so much for listening. I hope you learned something.